examiners, examinees, and also the all postgraduates to the 5th Pediatric Endocrinology for Postgraduates, a virtual teaching program. Last 4 sessions we have done very successfully. This time we have got 3 professors. My Professor Dr. Raghupati, who is a convener of this program, and Professor Anna Simon Madam from the CMC Vellore, and Dr. G.V. Subramaniam sir from Usmania Medical College, and the expert and examiner Dr. Anurag Bajpai from Kanpur. We welcome you all. Now I request my Professor Dr. Raghupati sir to start the session. Thank you, sir.
Good evening, everybody. I'm glad this session of pediatric endocrinology for specifically postgraduates doing pediatric medicine is going on as I wished and desired in the past. You all know that people who are training MD postgraduates in pediatrics or DNB pediatrics, all the centers do not have somebody who can teach pediatric endocrinology. So the candidates are always afraid, in constant fear regarding pediatric endocrinology questions and cases in the practical exam. And with the view to helping them, this program was started. And you may be knowing that parents also are always afraid of hormones. Hormones they think are bad. And so if you suggest thyroxine therapy, they will be, in two minds, whether they should continue lifelong and things like that, in spite of talking so much to them. And similarly, I think the postgraduates also have some fear about endocrinology. And the main essence of this program is to make the things easier for you to understand and also to carry out, and also to realize the importance of endocrinology and the wonders of endocrinology also. And without much further ado, I think we should go on to the program. We have a busy program. And I would only one thing I would like to add. We wish more participation from the postgraduate side. Those who are attending today, please go and tell them, tell the others, your colleagues, to join this program. We are going to have the next one in October, and to impress on them how we are tackling all the aspects with regard to the exam. And we are even including an OSCE session today also. And I would make this request to all of you to tell your colleagues to join this program. And also, you will be able to participate by presenting a case. And that will be also a very good exercise for you. And wish you all the very best for your exams and also for this program. I'm very grateful to Amarnath, who has taken, continuing interest for the whole year and for holding this session without fail. Thank you, Amarnath.
Thank you very much, sir.
Wish you all the very best.
Thank you very much. So the real treasure is only our teachers and the knowledge. So knowledge, we have to learn each and every second from each and every patient. So we have to spend maximum time with the patient. With this, today we have got the first case, that is the delayed puberty and Turner syndrome. The presentation is by Naga Geeta Rani from Sri Ramachandra Medical College, Chennai. The guide is Dr. Divya Lakshmi. She is the mentor and also the guide for her. And the examiner will be Dr. Anurag Bajpai sir. He is a well-known pediatric endocrinologist, author for many textbooks, presented so many national, international papers. And also my professor Dr. G.V. Subramaniam sir for General Pediatrics sake from Usmania Medical College. Over to you, sir. G.V. Subramaniam, sir, and uh, Anurag Bajpayee, sir. Geeta, you
Yes,
start
hi, sir.
presenting.
Sure, sir. So, good evening, one and all. Thank you for giving me this opportunity. Uh, Starting with the case details. A 10 years old girl child, first born of non consanguineous marriage, informant being mother and history reliable, was brought with chief complaints of poor height and weight gain in comparison to her peers from 1 to 2 years of age. History of present illness. The child has always been a thin and short child, always been the shortest in class, and the child poorly outgrows clothes, that is, school uniform every year, also been gaining weight poorly. Diet wise, she's a fussy eater and also takes small portion size. There is no history of polyuria or polydipsia or bony abnormalities, recurrent respiratory tract infections or recurrent diarrhea, no history of weight loss, fever, or loss of appetite, no history of constipation or cold intolerance or decline in scholastic performance, no history suggestive of raised intracranial pressure, no history of prolonged drug intake, and there's no history of appearance of secondary sexual characteristics. Past history was nil significant. Birth history, antenatally, mother was booked and immunized and was uneventful antenatal period, and mother had normal antenatal scans. Natal history, term 39 weeks gestation, delivered by normal vaginal delivery. Birth weight of the child was around 2.7 kgs and the child cried at birth. Postnatal history, no history of any NICU admission. Neonatal period was uneventful and the child was breastfed till 1 year of age. Family history, child is first born to a non-consanguineous marriage, single child. History of hypothyroidism was present in the mother, and there was short stature in the father and paternal grandmother noticed. No history of delayed puberty in parents, and there is no family history of tuberculosis. Developmental history, child attained age appropriate milestones and has good scholastic performance. Dietary history, as per 24-hour recall method, the child had a calorie deficit of 10.6% and a protein deficit of 5%. Immunization history, child is immunized up to date, and the child belongs to lower middle class 3 as per modified Kupusamy classification. Summary based on history, 10 years girl child, poor height and weight gain from 1 to 2 years of age, no history suggestive of any chronic systemic illness, and there is family history of short stature and hypothyroidism. Child had normal developmental milestones and good scholastic performance.
Okay, so you have got a very common presentation of a 10-year-old girl who has significant growth decline from around 1 to 2 years of age. So what do you really imply from having a growth failure which is onset not at birth, but after around 1 to 2 years? So which condition will you think of in this scenario?
So as per the ICP growth model, initially, if the child presents before infancy, the nutrition would be the more probable cause. But in childhood, the hormones come into play, like growth hormone and thyroid hormone come into play. So I'll think of hormonal causes more than nutritional causes.
Okay, good. And within hormonal causes, which cause is unlikely given your overall clinical description based on history?
Which hormone is unlikely, sir?
Which deficiency is unlikely in this scenario based upon your history? In fact, one of the points you've written here.
And thyroid hormone is not likely, sir, because there's no history of any constipation or. Yes, sir. Thyroid hormone deficiency is unlikely.
So pretty much from your perspective, if you look at it, it being predominantly a childhood onset growth failure with a normal intellect, then growth hormone deficiency would be something which is coming up in the scale.
Yes.
Anything else you will think of?
There can be familial short stature, sir, because there is family history of short stature. So I wanted to consider even familial short stature.
Okay, so do you think about a familial short stature or so you are saying that predominantly the paternal side, the father and the paternal grandmother is affected. So do you think that would go in more in a familial short stature or would it point towards a particular genetic etiology?
More towards particular genetic etiology. But
So inheritance are you looking at?
yes, sir. Yes, sir. Inherited short stature.
So which type of inheritance are you looking at?
From the family history, sir.
Yeah. Dominant. So you've got 3 generations which
Yes,
are affected. So you have to think of dominant. So I think you've done a very good summary. Sir, your takes on this?
Purvandam, sir.
Am I audible? Hello?
Yes, sir. You are audible, sir.
So, good evening, all. It is a nice presentation by you, but I would like to seek some clarification with regard to the natural details of this child. See, the problem has started right from 1 year of age, according to you. So, the problem, as you said, ICP model can be applied, but that more often the childhood is mid-childhood where you can think of an endocrinopathy more often. But in Indian scenario, we come across very often children with low birth weight, especially hypoplastic small fertility, dates and other categories. So the birth weight, gestation, and how are the babies, other aspects you did not, I think, you have not elaborated. If you can elaborate them, it will be much better. Because that may throw light. Suppose if it were to be a case of hypoplastic small fertility babies, you cannot have the same postnatal catch-up on par with peers. So therefore, I go by epidemiological reasons. I give due weightage. The most important determinant is the birth weight, and afterwards, how was the postnatal? So this this also I wanted to consider in this particular case because the problem has started much earlier.
So birth weight was 2.7 kg, I believe. Yeah.
Yes, sir. Birth weight was 2.7
39
kgs.
weeks, yeah. And 39 weeks, yeah.
Yes, sir. Term gestation.
Hmm.
Child did not have any midline facial defects, or since it's a girl child, and did not have any hypoglycemic, neonatal hypoglycemia events, anything like that significant.
What was the mode of delivery?
Normal vaginal delivery, sir. It was not a breech delivery. It was a cephalic presentation. So even a breech, no, we can consider growth hormone deficiency because it can be one of the predisposing feature. It was a cephalic presentation, normal vaginal delivery.
Geeta, can you think of any non-endocrine cause? You are telling again and again endocrine cause. Can you tell the short stature with non-endocrine cause which can present from birth or 1 or 2 years?
Syndromic, sir.
Very good, very good. What else? Something related to skeleton.
Skeletal dysplasia, sir.
Very good, excellent.
Skeletal dysplasia.
So one positive history is there in your skeletal dysplasia related history. Can you tell that? In your family history, something is positive. 3 generations, there is a short stature.
Yes, sir.
So what is the inheritance you think of?
Dominant inheritance.
Very good, excellent.
When you talk about nutrition, we talk about nutrition in the sense of food intake, but some other factors like malabsorption can also cause nutritional pattern of growth failure. Can you think of some nutritional disorder which will present around from 2 years of age, let's say, like this case?
Celiac disease or like that malabsorption syndrome, sir.
So classically, because that's when the weaning and other things are done. So it typically starts from that age group. Yes. So that is something, at least in our part, we will be considering that as a strong possibility from our side. Yeah, I think you can carry forward.
Yes. So provisional diagnosis of familial short stature can have hypothyroidism to rule out chronic systemic illness. Coming to physical examination, child was alert and active. Vitals, pulse rate was 98 per minute. Blood pressure 90 by 60 mm of mercury. Respiratory rate 18 per minute. All peripheral pulses were well felt and capillary refill was less than 3 seconds. No pallor, no icterus, cyanosis or clubbing, no lymphadenopathy or pedal edema was present. Head to toe examination. The child had pectus carinatum with widely spaced nipples, with no goiter, with low posterior hairline, and short 4th and 5th metacarpals and short 4th and 5th toes were present. Coming to anthropometry, Height of the child is 113.2 centimeters. When marked on IAP 2015 charts, it falls less than third percentile and the child is proportionate. Weight of the child is 19.4 kgs. When marked in IAP 2015 charts, falls less than third centile. BMI of the child is 15.19, falls in between 25th to 50th percentile as per IAP 2015 charts. So the father's height was 160 centimeters and mother's height 154.5 centimeters. And the mid-parental height, which is marked as a leftward facing arrow on the chart, falls on 150.7 centimeters. And the target height ranges between 144.7 to 156.7 centimeters, which is marked as upward and downward facing arrows in the chart. SMR staging, the child was prepubertal. And the child falls far below the mid-parental height.
So what is your interpretation of this growth chart? What does it tell you? What pattern of growth failure is it?
So the child is very far less than the mid-parental height.
Yeah.
So even not catching up somewhere with both the parents' height. So it can be genetic.
One, is she short for the population? Yes, very short.
Yes,
is
sir,
she
very
short
short.
for the family? You've said yes. The catch there would be that sometimes what happens is that if you have one particular parent who's very short, in this case, short but not that short, then you have to consider that this could be autosomal dominant inheritance. The third factor would be what is more affected, weight or height in this case?
Height, sir, because it started from very chronic. Now the child is around 10 years old. So we'll
So what is the
consider
weight age and what is the height age in this child?
it falls at 6 years, sir.
So both are the same.
Same,
so what
sir.
it basically means that both are equally affected. Now, what does it tell you? Is it a nutritional pattern or an endocrine pattern growth failure?
Endocrine pattern, sir. Nutrition, mostly weight is affected when height is preserved. So endocrine patterns.
So I think if you plotted the chart very nicely and it very clearly shows a pathological pattern of growth failure, which is definitely much below the parental expectation, which goes more with equal involvement of both height and weight, suggesting a endocrine pattern or a non-nutritional, let's put it this way, non-nutritional pattern of growth failure. That's fine. And what do you give the significance to the breast and pubic hair development?
Sorry, sir.
Younger children in long-standing nutritional deficit, your height also may get affected. But the age group is, of course, older side. Younger children, if the height is not affected, height also can be affected because of nutrition insert.
Yes,
there can be a proportionate dwarf in a child who is suffering from chronic undernutrition.
Okay,
But
sir.
of course, this will not fit into that. I agree that. But in general, you are making a generalization that height is not affected in nutrition. No. It can
Chronic,
be affected
yes, sir.
in some nutrition.
Yes, sir.
We cannot make sweeping generalizations. Huh?
Okay, sir.
What is the significance of pubertal status at this point of time?
Presently, in this child, 10 years old, the child will obviously be prepubertal, sir. But if at all there is any signs of secondary sexual characteristics development before, at 10 years of age, it compromises the final adult height of the child. So for that importance, I just put it as prepubertal.
Sure. That's perfect. So I think your diagnosis is pretty evident based upon your previous slide. So do you have any other thing on examination, other systems you want to comment specifically?
Other systems were normal, sir. Cardiovascular system, S1, S2 heard normally, no added sounds or murmurs. Respiratory system, normal vesicular breath sounds heard bilaterally. For abdomen, soft, no tenderness or no obvious palpable organomegaly. And central nervous system was also normal, sir.
What was the blood pressure?
Blood pressure was not falling at around the 90th centile, so 90 by 60 mm of Hg, right arm supine position.
You didn't measure blood pressure in other limbs?
All 4 limbs were measured, sir. Nearly normal. No.
You should
change.
mention that because that's a very
Sure,
specific
sir.
point
Yes, sir.
in this
Sure,
case.
sir.
Why do you measure in all 4 limbs? Do you measure in everybody?
No, so when we suspect any cardiac issues then we will measure all 4 limb BPs.
So I think that is a very, very relevant point that if you have a short girl who has got all these stigmata, which are clearly leading to Turner syndrome, that's
Yes,
why
sir.
you've done all the 4 limbs, and that would be a positive thing if you put forth right away. rather than waiting for being asked. So that will give you more relevance in that perspective. Yeah.
Sure,
So
sir.
that blood pressure and coarctation becomes a very, very important parameter to look at from that perspective.
Sure, sir.
Yeah, Geeta, one point here.
Yes, sir.
In general physical examination, you said multiple nevus. Can you tell what are the causes of multiple nevus with short stitcher?
Not sure, sir.
You have shown, no? Nevus?
Turner syndrome, I have known, sir. Other causes,
Yeah. Can you tell short stitcher with capillate spots?
Fanconi's anemia.
What else? An indication for growth hormone. Child has triangular faces, clinodactyly, hemiatrophy. Start with R. Childhood hypoglycemia.
Russell Silver
Very good,
syndrome.
very good. So capillate spot can present even in Turner syndrome also. Okay.
Yes, sir. Yes,
So
sir.
Russell-Silver syndrome. Very good.
The description about cardiovascular system should be, as a postgraduate, should be more comprehensive. It has to make a mention of how the peripheral pulses work. And apart from recording the blood pressure, she has done already all the 4 limbs. And a more clear description about cardiovascular is also warranted, I feel. There may be femoral pulses may be impaired with the coarctation, because as a postgraduate, when she is presenting, the specific reference should be made with regard to cardiovascular system. I think it should be more in a detailed manner, not a passing mention.
Sure.
Anurag, with your permission, may I make one point?
Definitely, sir. Please, sir.
And Geeta, can you show the clinical picture?
Yes, sir.
You mentioned this as pectus carinatum,
Yes, sir.
which is not right. And this is a common deformity which will be kept in the exam in a patient with rickets.
Yes.
And you can't call this pectus carinatum.
Okay.
Pectus carinatum is also known as
Pigeon breast.
Pigeon shape.
breast.
Pigeon shape. Yes.
Do you think this is pigeon chest? This is pectus. There is a depression.
Excavator.
Excavatum, you should say. I don't want people to go away thinking that this is carinatum, and this is for you and for all the postgraduates.
The funnel chest with depression of the sternum, lower half of the sternum is depressed. And that can cause, mind you, that can cause displacement of clinical displacement of apical impulse also. So
Yes.
I think it would be more prudent on your part to make a detailed mention of cardiovascular system.
Okay, sir.
Thank you.
Thank you, sir.
Yeah, go ahead.
So summary following examination, 10 years girl child, short stature from 1 to 2 years of age with poor weight gain, family history of short stature and hypothyroidism with normal developmental milestones and scholastic performance, with stigmata of Turner syndrome, without goiter and sexual maturity rating pre-pubertal, with a provisional diagnosis of short stature and underweight and Turner syndrome.
May I intervene a second? Because I want to clarify regarding.
Yeah, thank you, Divya. Divya Lakshmi is Associate Professor from Sri Ramachandra Medical College, who has provided the case immediately. Thank you, Divya. Please go ahead.
No, actually, she had pectus carinatum, this bulge that was very prominent. But I think in photo, it is looking like the child is having pectus excavatum, because following that bulge, she had that depression as well. So
I think, can we interpret this way? The upper half being more prominent and lower half
yes.
being depressed.
Yeah. Yeah.
Upper half is looked into, it is something labeled as pectus carinatum, but
Yeah.
lower half looking like a funnel chest. Sometimes the angulation may be acute and may give an impression. But all attendants, some chest cage deformity she has to refer to and classically describe what exactly is the defect that is there. That would be more a clear description. So label, assigning a label is one aspect, but more important is the description. Right?
Okay. Thank you.
One more point to Nagagita. Can you tell what is the nail finding of Turner syndrome? Nail finding.
Hyperconvex
Very good.
nails.
Very good.
Coming to the investigations of the child, complete blood picture showed normal hemoglobin 13 grams per deciliter with normal white blood cells and platelets. Thyroid stimulating hormone was 2.69 microinternational units per ml and free T4 1.27 nanograms per deciliter, which were normal in range. Serum creatinine was 0.6 mg per deciliter. Liver function tests were normal, total bilirubin 0.3. Transaminases were normal with normal total protein of 7.6 grams. Follicle stimulating hormone was 162 milli international units per ml and luteinizing hormone was 70 milli international units per ml, which were high. And estradiol was undetectable, less than 5 picograms per ml, pointing towards hypergonadotropic hypogonadism. Lipid profile was normal. TTG IgA was negative.
So just hold on. So if you look at this point of time, what is your diagnosis from here?
Hypergonadotropic hypogonadism, sir, because both FSH and LH were elevated and estradiol was undetectable. Otherwise, thyroid function tests were normal. And
in a short girl with all the classical features, your diagnosis would be
Turner syndrome. Turner syndrome.
Now, as a devil's advocate, I ask you, why would you do any further investigation like karyotype? So do you think this girl requires a karyotype from here, or your diagnosis is made and you can start treatment from here?
We can start treatment, sir, but
so
for
she
confirmation.
Has classical clinical feature. She is short, she has stigmata, and FSH is high. So what I'm trying to say that is, somebody saying karyotype is a very expensive test, I don't want to do a karyotype. Do you agree, or you say no, karyotype has to be done? And if yes, why?
For confirmation of diagnosis, yes, sir, we can do it.
Diagnosis is, from my clinical perspective, confirmed. Anything else? What is the very important role of karyotype in Turner syndrome besides confirming the diagnosis? Can it change the management somehow? In the sense that you may have to do some surgical intervention.
If at all there is, mosaicisms there or any Y chromosomes like that, sir, you mean to say like if at all there's a Y, we need to do a surgical intervention and remove the gonads because gonadoblastoma is more predominant.
So that's why karyotype is absolutely essential. Okay. So even if somebody says that, okay, I don't want to spend money to do a karyotype, you have to say, no, it has to be done because I want to rule out a Y cell.
Y cell, yes.
Carry
sure.
forward.
Okay. Thank you. Bone age of the child as per GP Atlas was 8.5 years. Echocardiogram done was normal with no abnormality. Ultrasound abdomen showed uterus size of 3.4 into 1.2 into 1 centimeters and endometrial thickness was 2.1 mm. Right and left ovaries were 13 into 8 mm and kidney, ureter, bladder were normal. Karyotyping was done with which revealed abnormal female chromosome complement in all cells with a single X chromosome showing 45X in 30 cells. Diagnosis of Turner syndrome. Management, we started the child on growth hormone since 2019 June, which was provided from the government hospital. Growth hormone dose was 0.1 units per kg per day. We have given 0.23 mg per kg per week approximately for the child. And follow-up, presently the child is 13 years old with the height of 129.7 centimeters and weight of 28.5 kgs. And the child grew 16.5 centimeters in 32 months, 8.5 centimeters in first 18 months and 8 centimeters in the next 14 months. This was due to the non-availability of growth hormone during the pandemic period. But post-lockdown, the compliance seems good. Current growth hormone dose for the child is 0.16 units per kg per day, around 0.37 mg per kg per week. Still, the child is prepubertal and bone age is 11 years for a chronological age of 13 years as of now. Following up with the thyroid function tests, which were normal, and the child was started on calcium and vitamin D supplements. Insulin like growth factor 1 and TTG were not done due to logistic reasons, and child was planned to start on low dose estrogen supplementation. Thank you, sir.
So do you need to do a growth hormone testing in this child before you start growth hormone?
Not necessarily, so we can directly start the child on growth hormones.
And how is the dose? It may be a bit more for you, but how is the dose different for Turner as compared to growth hormone deficiency? Do you need a higher dose or a lower dose?
we can start initially with the normal prescribed dose, sir, but if at all it is not catching up, we can increase double the times when compared to a normal growth hormone.
So just
Deficiency.
a small comment that probably we could have started at a higher dose. The initial dose was around 33 microgram per kg per day, I think 0.1 units.
Yes, sir.
But probably if we start by 45 to 50, that would be the recommended dose for Turners because they require a bit more. And that's what you're probably getting at, that initial growth velocity was a bit less. Then once the dose was increased, the response is better on that. But that's beyond this case discussion from a postgraduate perspective. That's fine.
Thank you very much, Dr. Geeta. Just one small question.
Yes,
Any special growth charts you know about this condition?
Yes, sir. There are special growth charts for few syndromes. Like Turner syndrome also has a special growth chart, and there are also other special growth charts for.
Are you aware of Indian specific Turner growth chart?
Yes, sir.
Very good. Thank you.
Thank you, sir.
Thank you very much, both the
One question to the student.
Yes.
In this particular case, the both mid-parental height is quite low, and the child is lagging quite behind. Is it not? So
Yes.
there is a possibility of a familial component also in this particular case. You said the growth hormone assessment is not needed initially. Straight away you embark upon growth hormone, of course, which may be a bit costly also. But how do you justify yourself? See, if there is associated growth hormone deficiency, as SAR said, it may require larger doses. So, can we come to a conclusion that the child doesn't have any growth hormone issues based on parental height, or you want to have a check before? Is my question before we embark upon.
We are like, since the child had stigmata, we are not suspecting isolated growth hormone deficiency, sir. That's
No.
why
Isolated is not the point. Okay. Right. Isolated growth hormone, we are not suspecting for the stigmata because
the
of
stigmata. So in this child, we went ahead with growth hormone directly, sir. But if at all we are suspecting a short for not falling in the sentence of mid-parental height, then we definitely need to do a growth hormone stimulation test, and then confirm it and then provide growth hormone for the child.
I think the answer to your question, the question also already is there in what you were discussing, that since this is more of a pharmacological treatment, even if the growth hormone is low or normal, Turner syndrome itself becomes an indication. So that is not going to change your management dramatically. That's why we don't routinely measure. But of course, if a Turner girl is deviating significantly from the Turner's chart, then you have to think of alternate diagnosis in that scenario. And that's a very, very important question in that regard. So, but in this case, there's a classical Turner's, you have diagnosed based upon karyotype. And she's pretty much fitting into the Turner's growth chart if I look at it from that perspective. So we don't expect additional pathology. They usually are 20 centimeters below the expected height. So that is a reasonable to start treatment, and growth hormone stimulation would not be required in that scenario, in that perspective. But definitely, as sir said, that if there is a significant deviation, the possibility of an associated etiology also becomes important in that regards.
Okay, sir. Thank you, sir.
Thank you very much, sir.
Dr. Anurag. Dr. Geeta.
Yes, sir. Yes, sir.
It's good growth, actually, 8.5 centimeter in first 18 months. Okay, that's 18 months, not 1 year. I think the compliance was poor. If you see the growth chart, there is no increment in the height, right?
Yes,
it has not jumped up like how you give growth hormone.
Yes, ma'am.
Because your dose is quite less.
Okay.
Turner syndrome, the dose should be much more than what you are given here.
Yes, ma'am.
Later dose are better. So if you see last, Dr. Shaila, the last dose is touching around 50. So initial dose was definitely 30, 35. So that's why there is
written the current dose is...
current dose for the child is 0.37 mg per kg per week is going, ma'am.
So that's like 50 microgram per kg per day. Yeah, that's a good dose. Yeah.
So if the compliance is good, I think she should have a little bit more increased. That is one thing. And if they can take growth hormone, I think IGF should always be done. if you are planning to increase the dose, if the growth
Yes.
velocity is not good, you can't jump and give a very much higher dose. So IGF measurement should be mandatory in this kind of conditions when you are targeting a higher dose for better response. So that would be
Sure, ma'am.
two things.
Okay.
And definitely excluding other secondary causes like follow-up thyroid and celiac on follow-up as well, which is there too.
Yeah, I think those two things have to be done. Even the TTGA, even though I know there may be a South Indian or Tamilian, we do see a lot of patients who are not North Indians. So, and if there is a Turner syndrome, other autoimmune conditions are more likely. So cortisol, thyroid, TTGA with total IgA should be done.
Yes, ma'am.
We thank Dr. Shaila Bhattacharya Madam. She is a professor of pediatric endocrinology from Manipal Hospital and from Davangere. She is our president, very dynamic president. Thank you very much for joining, Madam. Now we request Anurag sir to give lecture on delayed puberty and Turner syndrome. Thank you very much.
Thanks a lot, Dr. Amarnath, for this kind invitation and for inviting me for this very, very interesting aspect. So what I'll do over the next 20 minutes or so is to cover the relevant aspects of delayed puberty, both in terms of boys and girls. And this is a very, very wide and diverse field in which we need to be very careful in terms of evaluation and management. And this is very relevant because as short stature, delayed puberty may also be a sign of an underlying disease which may have significant pathological connotations as well. So if you're dealing with a child who has delayed puberty, you need to be aware that there could be other disorders which are also there in that regards. Similarly, a lot of these are physiological. So we need to be careful that we do not unnecessarily label them as pathology. So I'll start with a 13-year-old girl with concern for delayed puberty, who was brought by parents with a stage 1 breast development and stage 1 pubic hair development. She was short for that particular height, weight was reasonably all right, and the workup had shown our LH and FSH levels were low. Ultrasound had been done which showed an absent uterus. Now, this seems to be a very devastating diagnosis because parents are really concerned about delayed puberty, and what you're finding is that there are no uterus which is found on ultrasound. Now, what is the problem occurring in this scenario? So what we need to understand is that this is just at the time when we start thinking about delayed puberty in girls. And if you do not have any breast development, which basically means that you don't have any estrogen exposure, you are expected to have a very, very small hypoplastic uterus, which may actually be missed on ultrasound by radiologists, and that could be labeled as a quote unquote absent uterus. So this was a case wherein an unnecessary workup was done and a child was labeled as significant pathology. So this is something which we need to really avoid. On the contrary, we have the 16-year-old boy who again presented with pubertal concern. Onset was at the age of 13 years and there was no development for the last 2 years. Had a small testicular volume, which was soft, stage 3, pubic hair. Height was 170 centimeters, so tall in that perspective, diagnosed as CDGP. Now, when I'm going to talk about what really is not CDGP, is somebody who is tall, somebody who has got good pubic hair development, somebody who had onset and then has stalled. So this child had everything which was against CDGP, but yes, was labeled CDGP based upon a low level of gonadotrophins. And when we got the MRI done, it showed a large tumor. So what we need to understand is that delayed puberty is a common presentation. Boys with delayed puberty are more likely to present as compared to girls, but the chance of pathological cause is higher in girls. Still, 1/3 of girls will have a physiological cause, while a significant pathology will be around 30%, and 30% will have a systemic disorder or a functional cause. As far as boys are concerned, 70 to 80% will be physiological. There will be disorders in around 30%. So the main role of a pediatrician is to really identify the physiological cause, as in the first case, and not to miss the pathological cause, as in the second case, because that's where we have to be cautious in terms of timely evaluation and management, and that becomes absolutely essential. courses which are available can also be accessed. So we'll talk about delayed puberty a bit, about etiology, why is there delayed puberty, how to evaluate and how to manage. And since it's only 15-20 minutes, I'll focus predominantly to give a holistic approach in that perspective instead of going into very specifics on that regards. You can refer to other resources on the web and the website which you can evaluate from there. Now, when we talk about puberty, we understand that there are three major organs, the hypothalamus, the pituitary, and the gonads, which interact with each other. And there are three major hormones, the GnRH coming from the hypothalamus, which is the primary driver of pubertal onset, the gonadotrophins from the puberty, the LH and FSH, LH being a major player in boys and FSH being the major player in girls, while both are required in concert in both genders, and the ovaries and testes which produce finally the sex hormones. Now the problems could either be at the level of the hypothalamus or the pituitary in what is known as hypogonadotropic hypogonadism, characterized by low levels of gonadotrophins, which will include a combination of genetic causes. Most common of them would be isolated defects in GnRH migration. Now we all know that GnRH neurons migrate from the olfactory placode near the nose to the pituitary region, the hypothalamic region, and along with them come the sense neuron, the olfactory neuron, and therefore abnormalities in puberty are often associated with anosmia, and that is one thing you should always ask as far as history is concerned. There could also be a combined hypothalamic pituitary defect in which you have multiple pituitary hormone deficiency. There could be an acquired cause in which you may have a normal development and then suddenly something happened, just like the second case, which could be in the form of a trauma, radiation, infection, or a tumor. So a situation in which you have a stalled puberty is a sign of a pathological cause which you have to be really worried about in that regards. There could also be infiltrative disorders, and very importantly, especially in girls, any condition which is affecting the nutrition, any form of stress, calorie deprivation, systemic illness will also cause the pituitary to shut down, and you will have hypogonadotropic hypogonadism. So before you label somebody as isolated hypogonadotropic hypogonadism, exclude all the chronic systemic causes as you do for short stature, renal disorder, liver disease, malabsorption, renal tubular acidosis, hyperprolactinemia, and an insult, and then only go for an idiopathic cause in that perspective. The second group of disorders can be the ones in which the gonads are affected, in which you have got hypergonadotropic or a high FSH level. Remember, FSH elevation is the best marker of hypergonadotropic hypogonadism, and in this case, the FSH was more than 100, if you recall the presentation recently. The problems could be at the level of the gonadal development. Most common causes will be Turner syndrome, as was the case discussed just before, and Klinefelter syndrome in boys. Now, Klinefelter syndrome is an interesting finding in which you will have some initial development and then there will be regression. So testicular volume will go up to around 10 ml, and then there would be regression of testis. There would be some amount of pubic hair. There will be gynecomastia. So Klinefelter syndrome, if you talk about the truest sense of the word, is a stalled puberty and not a classical delayed puberty from that perspective. But again, in boys, if your FSH is high, think Klinefelter syndrome. There could also be rare cases of gonadal dysgenesis, which can also cause delayed puberty, particularly in a female phenotype, where you will find that abnormalities in the synthesis of steroids, testosterone, and estrogen can cause a combined adrenal or an isolated gonadal defect in that perspective. There could also be an insult of the gonads due to infection, drugs, radiation, or infiltration because of autoimmune cause, particularly relevant in the girls, which causes premature ovarian insufficiency. So we need to understand that when we talk about delayed puberty, we are talking about either a problem in the hypothalamus or pituitary, which is a permanent problem, or because of the environment, which is a functional problem, or a primary gonad problem in that perspective. So delayed puberty can mostly be physiological. As I said, 70 to 80% in boys, 1/3 in girls is physiological, and the term now is self-limited delayed puberty. This condition is characterized by slow growth. So everything is shut down, growth is less, there is no pubarchy. There could be a pathological cause, of course, in around 60 to 70% of girls and around 30% of boys. Within this, you can have hypogonadotropic hypogonadism, where the FSH level is low. It can be congenital right from birth. And if you have a boy with micropenis and delayed puberty, always think of a congenital cause. Or if you have a midline defect, cleft lip, cleft palate, hypoglycemia, neonatal cholestasis, this could be a multiple pituitary hormone deficiency. There could be acquired causes like tumor, infiltration, or insult, which will of course have a neurological features, just like the second case. Now, often we tend to miss them and we say everything is physiological, and we will miss this cause in that perspective. Very important, any chronic systemic illness which causes stress and calorie deprivation will also cause hypogonadotropic hypogonadism. These individuals will be sick in that perspective. Now, if you go to the other arm, if your gonadotrophins are high, FSH is high, you are dealing with a gonadal problem, which could be a dysgenesis, classically Turner's and Klinefelter's in most scenarios. You will have stigmata, like we discussed here, brachymetacarpia, hyperconvex nail, you will have multiple nevi, webbing of neck. In boys, you will have gynecomastia, tall stature, large legs, increased arm span. That is a typical characteristic of Klinefelter syndrome, which will be there. Synthetic defects in which you will have other features. So if you have a salt wasting with a female appearance, you're dealing with a very, very proximal defects. If you have hypertension and sexual infantilism, you're dealing with 17-hydroxylase deficiency. And finally, if you have an acquired cause, most likely in girls will be an autoimmune etiology. In boys, you can have a testicular torsion. If it's bilateral only, there will be an effect in that perspective. So most cases are physiological, but you need to understand when to think of pathology in that perspective. So 3 questions which are very, very important. Is it delayed puberty? Is it pathological or physiological? Is it hypogonadotropic or hypergonadotropic? And finally, what's the cause? So the definition of delayed puberty in girls is absence of thelarchy by 3 years or no menarche within 4 years of thelarchy. So as discussed, the first case, 13 years was just a borderline scenario. In boys, no testicular enlargement by 14 years, or if there is a stalled development and then it stopped. And very importantly, no role of pubic hair or penile length in the assessment of delayed puberty in boys. So as discussed in the first case, we had this 13-year-old girl with concern for delayed puberty. It was too early for evaluate. Best would have been to wait and watch and what havoc was caused by this, because parents was convinced that this is absent uterus, going to be a lot of problems, MRI and a lot of things. So don't unnecessarily over evaluate in that perspective. Now, this 8-year-old boy with small phallus, concerned about micropenis, very common presentation, but this child is obese and this happened to have a buried penis. So first of all, penile size is not relevant in diagnosing delayed puberty. Number 2, whenever you're measuring penile size, do a stretched penile length and you will find a normal growth in that perspective. The next question is pathological versus physiological. So I would say the term is very simple. When you say constitutional delay of puberty and growth, you are talking about delay in both puberty and growth. So height should be less. Second, if you are having no gonadarchy, your testes and ovaries are not working, your adrenals should also be sleeping. So you will have no adrenarchy, and because adrenals cause pubic hair development, you should theoretically have no pubic hair development. Bone age should be delayed. The problem is in onset. So once the onset happens, you will not have a stalled puberty in that perspective. So if you have retarded growth, bone age, absent pubic hair, and a slightly bigger testicular volume, especially in boys, we are most likely dealing with a constitutional delay of puberty and growth. On the contrary, if you have a tall child with a normal bone age, with a normal pubic hair, it goes more in favor of an isolated hypogonadotropic hypogonadism. There are various tests which are done to differentiate the two. There are no best way. The best way is to actually follow them up till 18 years and see whether they have a normal development or not. But tests which I find helpful in my scenario is a GnRS stimulated LH level more than 5, a inhibin level more than 35 if a testicular volume is around 1 ml, and a basal testosterone more than 20. So you can have an idea based upon doing this test to differentiate CDGP from a permanent hypogonadotropic hypogonadism in that regards. Now, what are the clinical pointers? As I said, delayed growth, absence of pubar, Then delayed bone age suggests a self-limited form of delayed puberty. On the contrary, if you have pubarchy, which means adenarchy has happened, so why is gonadarchy sleeping? Stalled puberty, second case, if you remember, initial puberty and then stop. This is a sinister sign. Normal growth, why is the child not growing and puberty not happening? And of course, if there is history of micropenis, that suggests an antenatal origin in that regards. Similarly, if there is midline defects like cleft lip, cleft palate, if there are neurological features, if there is synkinesia or other features of hypogonadotropic hypogonadism like anosmia, start thinking of a permanent cause. So this becomes very, very important when you examine the child for the first time in that regards. So 14-year-old boy with delayed puberty, testicular volume is 3 ml, just below 4 ml, so not really that much delayed, I would say. We also find that there is no pubic hair development. The child looks to be short. There is growth retardation. Bone age is delayed. So now we are dealing with predominantly what looks like a constitutional delay of puberty and growth. The other differential here will be a chronic systemic illness, but there the child will be more sick in that perspective. And when we did evaluation, we found that there was a normal pubertal response. So this is a classical case of CDGP, delayed growth, delayed gonadarchy, delayed pubarchy, and the bone age is also delayed. So you don't need to do much. Wait, watch, and observe. The child will grow subsequently. Now, what about 16-year-old boy? This is another child who had an onset at 13 years, stopped for 2 years, and this is what we discussed. There is a height, which is good. There is pubic hair development. So there are all the markers which are against the diagnosis of constitutional delay, yet labeled at CDGP. So this child had pubarchy, he had stalled development, he had normal growth. So this means there is an acquired cause of delayed puberty and clearly found to be a large craniopharyngioma. So while 70 to 80% of boys will have a physiological cause, if they are tall, if they have neurological features, if they have pubic hair development, if there is a stalled puberty, do MRI if the LHFSH is low. Don't wait and watch in that perspective. Now, once we know it's pathological, the next question is hypo versus hyper. The answer is very easy. Look at FSH. When you're looking at precocious puberty, as Dr. Anna will talk about, you have to look at LH being a predominant marker. Here you look at FSH, and FSH levels are really high. In girls especially, the FSH will be above 60 to 100 because there is no inhibin D. In boys also, the FSH will be like 20, 30. So you won't have any confusion between a hypogonadotropic versus a hypergonadotropic hypogonadism in that scenario. So 17-year-old boy with pubertal concern, onset at 12 years, stopped for 3 years. Now this is significant. This cannot be CDGP because there is a stalled puberty which has happened. Testis is 2 ml, it's firm, and there is gynecomastia. So I've already given 3 big clues: stalled puberty, firm testis, gynecomastia, height is tall. So this is all the thing written up there. This is a hypergonadotropic hypogonadism because of Klinefelter syndrome, which you have to be very, very wary about and evaluate from that perspective. Finally, we have to look at the cause and there start with clinical evaluation. I found pubic hair very, very relevant. If you have no breast development, but pubic hair is there, which means pubarchy has happened, this is most likely a hypogonadotropic hypogonadism. If there is no breast development, no pubic hair development, this is classically a constitutional delay of puberty and growth. It can also be a manifestation of a sick child, rarely a child with multiple pituitary hormone deficiency, where your ACTH is also knocked out, will have no breast, no pubic hair. If, on the other hand, you have a large breast development, but there is primary amenorrhea, there is very sparse pubic hair, this is interesting. This suggests that there is an androgen insensitivity syndrome. And finally, if you have got normal pubarchy, normal breast development, but no periods, this is suggestive of a local cause, a malformation like cervical or mullerian agenesis in that regards. So look at pubic hair, look at breast. 90% of cases your diagnosis will be made in that perspective. What about boys? The most important thing to look at in a boy with delayed puberty is the testicular volume. So if you have a large testis with delayed puberty, this is interesting. This is basically hypothyroidism, where uncontrolledly high TSH causes FSH elevation and macroorchidism, but Leydig cells are sleeping, so you will have delayed puberty. Rare, but interesting. If you have very small and soft 1 ml testis, this is Kalaman syndrome. Ask for anosmia. You will get the history. If you have an intermediate 3 ml, something like that testis, you're dealing with constitutional delay. If you had a history of bigger testis, which have now become small and firm, just like the 5th case, which we discussed, this is Klinefelter syndrome classically. And of course, you can have anorchia or a DSD also, which can present in which you have no gonad. Polydactyly to look for Lawrence von Butel syndrome. Hearing defect with delayed puberty, think of Turner syndrome, charge and pseudohypoparathyroidism. Brachymetacarpia, as very nicely showed in this case, Turner syndrome. If you have short stature, Turner syndrome, and multiple pituitary hormone deficiency, look for blood pressure, again reiterated in the first case, Turner syndrome, and sexual infantilism with severe hypertension, hypokalemic alkalosis, that 17-hydroxylase deficiency. Now, just to summarize the approach, first of all, start with screening tests, CBC, liver function, renal function, celiac, thyroid, and look at prolactin also. If your gonadotropins is low in a girl, you can go for a GnRH agonist and an MRI. If your gonadotropins are high, look for karyotype to identify Turner syndrome. If it's a normal karyotype, then it becomes a bit difficult. You can think of a genetic workup. You can think of other rarer possibilities from there. And if it's XY rarely, it means that there is definitely a scenario of a XY disorder of sexual development. So your FSH levels, like in this case, will guide your evaluation. In the case discussed with us, the FSH was very high, karyotype was XO, so this was Turner syndrome classically in that scenario. What about boys? Again, do the basic screening test. If gonadotropins is high, this is most likely Klinefelter syndrome. Do a karyotype. If the gonadotropins are low, you're either dealing with constitutional delay of puberty in growth or hypogonadotropic hypogonadism. So if you have anosmia, synkinesia, micropenis, CNS features, you can probably go for MRI directly. Otherwise, if the testosterone is above 20, this is basically going towards CDGP. If it's below 20, look at LH. If LH is more than 0.2, it again goes towards a CDGP. If it's low and stimulated is above 5, this is CDGP. Otherwise, it's permanent HH. So evaluation based upon how much is your gonadotropin levels, then look at testosterone and LH, you will get the diagnosis in most cases. This is a simplistic approach. We also now use inhibin B as a good marker of Sertoli cell function, which gives us a very, very good results in that perspective. We have also developed a puberty interpreter and we have validated it using very, very basic tools. So all the user has to do in a mobile application is to enter the basic details about the breast and the pubic hair development in girls and testicular volume, and they will get a right information about the precocious and delayed puberty. And we have found it to have a 97.8% concordance with clinical diagnosis. So this is something you can use very easy to interpret in that regards. So 12-year-old girl with growth failure, already discussed in this case today, short, no breast development, no pubic hair development, brachymetacarpia and webbing, all the classical features, FSH high, advised growth hormone, but somebody forgot to do a karyotype, presented 3 years later with an abdominal lump. Very important message, every girl with, even if you have 100% diagnosis of Turner syndrome clinically and high FSH, get a 30-cell metaphase karyotype done, because you can't miss Y cell line. Otherwise, there will be gonadoblastoma, which will happen in that perspective. 16-year-old girl with delayed puberty, stage 1 breast development, no pubic hair. So again, no pubic hair suggests either CDGP or systemic illness. Now, this child is short, weight is also less, LH and FSH both are low. So is it hypogonadotropic hypogonadism? Advised for MRI. Now, if you look at basically the evaluation and enter the parameters, this looks like a recommendation for systemic illness. There is anemia, there is clubbing. So this turned out to be celiac disease. So before you label other rarer disorders, look at common conditions first in that regards. 14-year-old girl with delayed puberty, again, short and plump. Short and plump, always think of an endocrine cause. And what we found here was the gonadotropins was slightly high, not as high as Turner's. There was also a karyotype was normal. There was deafness and brachymetacarpia. So here we are dealing with pseudo hypoparathyroidism, other possibility. So other possibilities are also relevant from that regards. 14.5-year-old girl with delayed puberty, no breast development, pubic hair stage 1. And what we're seeing here is that gonadotropin levels are very high. So this is a hypergonadotropic hypogonadism. One thing you should always do in this girl is to check blood pressure. If the blood pressure is very high, you get the diagnosis. So what we found here, karyotype was normal, blood pressure was very high, turned out to be a 17-hydroxylase deficiency. So if you look at careful parameters, look at deafness, look at blood pressure, look at anosmia, you will get a lot of diagnosis right in that regards. How do you manage? Very briefly, so if you have a boy who's beyond 14 years of age and you have got low LH, give a course of testosterone 100 milligrams for 3 doses every month. If there is a response, this is CDGP. If there is no response, you can repeat a course for 3 months. Response again, it is CDGP in most cases. If there is no response or the testosterone levels remains low, think of a permanent hypogonadotropic hypogonadism. So the gold standard for diagnosing CDGP is the clinical response and response to testosterone. We always start with a low dose, 50 to 100 milligrams, and then build up the adult doses gradually over 2 to 2.5 years. There are other long-acting preparations available for maintenance, and gel and oral preparations are not recommended in children. There is a chance of fertility in hypogonadotropic hypogonadism using HCG and HNG, and donor insemination can be used in hypogonadotropic hypogonadism. In girls, the recommendation is to start off at a very low dose of approximately 10% of the adult dose. Try to build it over 2.5 years. We tend to prefer estradiol valerate, and transdermal is of course more physiological, but it is difficultly less available. Progesterone is added only after minimum of 2 years of estrogen to allow breast and uterine growth, or if the bleeding has happened or the endometrial thickness is more than 5 mm. So a slow, gradual pubertal induction is what we look at. If you have a delayed diagnosis of Turner syndrome, we have to be slow and cautious in that perspective. So all of you can go and have a look at our website, which has got a lot of courses available, including fellowship and postgraduate courses as well, and the applications which are there. We routinely have multiple grant rounds, both for the pediatric endocrine fellows, for pediatricians, as well as a PG lecture series, which we run monthly, in which we aim to cover 36 topics over the next 3 years. We already had around 6 presentations there, so all of you can have a look there as well. Once again, thanks a lot, Dr. Amarnath, Dr. Puberty, and the entire team for the wonderful opportunity and interaction. Thank you.
Thank you very much, sir. Sir is a very dynamic teacher. He wrote and authored a textbook of pediatric endocrinology during his PG period in AIMS. So we should learn a lot of things from him. We need your blessing, sir. I thank sir for giving very brief and extensive workup and very short and simple diagnosis. Just by doing general physical examination, you can diagnose any condition. Thank you very much. Now we'll move on to the next session. Any comments from Shaila Madam, Raghupati sir, Subramaniam sir? We thank Jivalakshmi and Nagagita for excellent case. Now we'll move on to the next session on ISPAE pediatrics, mainly on puberty. So most of the things covered delayed puberty by Anurag sir. Thank you. Over to Dr. Soundaram. Dr. Soundaram is a consultant pediatric endocrinologist, Apollo Hospital, Chennai, and also Apollo Proton Cancer Center, Chennai. And we thank Soundaram for readily accepting as a teacher and also giving the second case, that is precocious puberty from Apollo Chennai Hospital. Thank you. Over to you, Soundaram. So this is a OSCE session. We give 5 to 10 seconds time to interact with the postgraduates. We'll be looking into chat box, so you can answer all the answers in the chat box. Thank you.
A very good evening to all the professors and postgraduates. So I would like to thank Dr. Amarnath for giving me this opportunity today. So let's go into the OSCE. So this is the first question. So identify the breast age. So all of you are aware of the Tanner's sexual maturity rating. So I would like you to answer what breast age this is. Okay, so you have to remember that there are 5 stages of breast development. So you have to remember it like a sequence. So B1 means it is absolutely flat, and B2 means only the areolar enlargement and the papillary elevation is there. So the first step is just areolar enlargement with papillary elevation, and the third stage is the breast mound is being formed. So there is an elevation from the chest wall. So that is B3. Now, if you see this breast, the areola is forming a secondary mound over the breast. So this is B4. Okay, and B5 means just like this, but there will not be any contour separation between the areola and the rest of the breast tissue. That is breast 5. So this is stage 4. Okay, so going on to the next question. So can you tell me what stage of pubic hair development is this?
Yes, all of you answer. Stage 3, someone saying.
Okay. So actually, I'm not able to see the chat results for this question.
Yeah, I will be telling. Yeah,
Okay, sir. So
stage 3.
actually, yeah. So the second question says, when will the pubic hair start to curl? So this also has a sequence you can just remember. P1 means there is no hair at all. Sometimes very fine straight hair can be there from infancy itself. That is called as vellus hair. So that you should not classify as mature pubic hair. So just ask the mom if there is fine straight hair on the pubic area right from infancy, then that also becomes P1 only. In P2 also there will be straight hair but little bit longer. You can compare with the forearm hair. If it is longer and lighter, then it becomes P2. And in stage 3 only the pubic hair will start to curl. Okay, so that answers the second question. So it will start to curl in P3. And the third question is identify the pubic hair stage. So here you can see that in P3 when the hair starts to curl, it is mainly around the scrotum and in the symphysis pubis area that it will be seen. In stage 4, it will occupy the entire external genitalia, the entire pubic area. So this is P4. In P5, what will happen is the adjacent groin, the inner aspect of the thigh also will have pubic hair. So this one is P4. So when will the growth spurt happen in girls? In which breast stage does growth spurt happen in girls? Okay, so Yogavali has told stage 2 to 3, that is right. So girls will have a very early growth spurt in the early stages of pubertal development. So in which stage does do boys get their growth spurt? Yeah, that's right. So stage 3 to 4. So boys will have a later growth spurt and also a more growth velocity during the pubertal years. So the girls will grow like 8 to 10 centimeter per year for 2 years or so, whereas the boys will grow 10 to 12 centimeter per year, and they have a delayed growth spurt. I mean, delayed means comparatively the Tanner stage is late. So stage 3 to 4, they will have a growth spurt and it will be more prolonged. So that's why the adult height difference is there of 13 centimeter between the boys and girls, because of the delayed onset of the pubertal growth spurt as well as the more increase in the pubertal growth during the growing phase. And when does menarche happen in girls? In which breast stage? Yeah, right. So B3 to B4, children can develop menses. Okay, so going on to the next question.
Just 1 second. There is a small background noise. Can you check, Saundram, from your side? Sorry to interrupt. Yeah.
Okay, sir.
Yeah.
So this
Go
is
ahead.
from the Nelson textbook. So all of you must be aware. So I've just underlined the main points which I have already told you. So in B2, there will be papillary elevation. And in B3, the breast will elevate from the chest wall. And P3, so I told you the hair will start to curl. And B4, there will be a secondary mound formation. And in penis, one important thing is the glans will appear like a pyramidal structure, which will be more prominent in the 4th stage. So some important points I've just underlined for you. So these are the answers. So we will be giving the handout to you. So I've just written the answers what we have discussed. So going on to the next case. So this is a 18-month-old child noted to have breast development since the first month of life. And you can see that the length is normal. It is on the 50th centile only. And SMR, if you see, is B3, A1, P1. So you should notice that there is no growth, abnormal increase in height, and there is no pubic hair. Okay, so these two are important clues for you, and the onset during the first year of life itself, that is also an important clue for you. So on lab investigations, you see that there is no pubertal enlargement of the uterus. So uterus is very small for age, appropriate for age, and ultrasound shows several microcysts. So these are all clues towards your diagnosis. So usually the breast development is because of the estradiol production from the ovary. So that estradiol production only leads to uterine enlargement also. But you see here the estradiol effect is there on the breast, but the estradiol effect is not there on the uterus. Okay, so there is some selective selectivity of the estradiol action. So that is made out in the question itself. And bone age also, if you see, there is no bone age advancement. So the next clue, so there is no height increase, there is no bone age advancement. And the L in the bloods, LH is prepubertal 0.1 and FSH is mildly elevated. So these are the clues you have got. So what's the diagnosis? So from the clues you have got, can you make the diagnosis? So there is only selective enlargement of the breast tissue here. Any PGs know the answer? Yeah, it is premature thylarch. Okay. So how will you, and what is the etiology of this condition you think? Why is it happening? Actually, it is because of idiopathic hyperfunction of the pituitary ovarian axis. So actually, we don't know for what reason the pituitary ovarian axis is getting stimulated, but it gets stimulated on an intermittent basis and very transiently estradiol production is there, and there is selective estrogen sensitivity is more in the breast tissue. That's why only the breast gets enlarged. So it is because of idiopathic subtle hyperfunction of the pituitary ovarian axis. Okay, so how to differentiate from CPP? That is the most important thing, because CPP we need to treat it differently. So you need to differentiate a premature thylarch from a CPP. So how do you do that? Okay, so I told you from the clues itself. So in CPP, central precocious puberty, pubic hair development will be there. Here, pubic hair development is not there. And in central precocious puberty, there will be a growth spot. So this child did not have a growth spot. This child did not have a bone age advancement. And the LH value also is pre-pubertal. In CPP, the LH value also will be increased like 0.3 or more. And ultrasound will show uterine the uterine configuration will be pubertal. That is, above 3.5 centimeter will be the uterine length. So you have to see the uterine length. It will be more than 3.5 centimeter. That is pubertal uterus. And ovarian volume also will be more than 2 ml if it is pubertal. So the ovarian volume, the uterine length are more important in the ultrasound. And these several microcysts in ovary are there in the premature thylarch because of the increased FSH I told you, which stimulates the antral follicles. So these small follicles are seen as several microcysts in the ovary. So, so going on to the next question. So what is the treatment for premature thylarch? So what should you do if you diagnose premature thylarch? Correct, reassurance. So you have to tell the parents that this is a very self-limited condition and they just need to come for regular follow-up, because on very rare occasions, the premature thylarch can progress to central precocious puberty. So we need to keep the child under monitoring, but those premature thylarch which have onset in the infancy are mostly self-limited in 90% of the cases. Those premature thylarch which happen later in the childhood, you have to be more cautious because they can progress to CPP on a higher risk. Okay, so those children you have to be more cautious. But for the diagnosis of premature thylarch, there is no treatment. You have to just keep them under follow-up and reassure the parents. So the answers I've just put it for you. Okay, so going on to the next question. So this is a 6-year-old girl whose height is 1 minute. Just a minute. Okay, so this is a 6-year-old girl who has a height of 100 centimeters. So she is short for age. The height age is only 4 years and weight is 23 kg. So her weight falls between the 90 to 97 centile. So she is short and she is fat. And Thilark noted recently and Menard 2 days ago. So there is a very short tempo of progression of puberty. Usually the tempo of progression of puberty is 2 to 3 years from the time of breast development to menses. So here you are seeing like a mother says that just Thilark appeared few weeks back and then menses has appeared. So this is a very short history and bone age is 3.8 years, which is very much delayed. Significant delay is more than 2 years. So you have a very short child who is fat and who does not have the usual pubertal progression and who has a severe bone age delay. So these are the clues you have got. And on the graph, you can see that I have put a small triangle here. So this triangle denotes the bone age. Okay, so for the bone age, so how do you plot the bone age? So you have to drop a perpendicular from the height. So I have plotted the height at 100 centimeter for 6 years. So from that point, you have to draw a line to 3.8 years. So this line I have drawn, like you have to draw a perpendicular from 3.8 years to 100 centimeter. So that denotes the bone age. So now what is the diagnosis you're thinking of? So what are the causes of short and fat children? So short and fat children are mostly endocrine short stature. So the causes you know are hypothyroidism, growth hormone deficiency, Cushing syndrome, and pseudo-hypoparathyroidism. So which of these can cause precocious puberty? Among these four, which do you think can cause precocious puberty? So that gives you the next question. So what blood test will clinch the diagnosis? So what are you thinking as the diagnosis? Now what test do you want to order for this confirmation? Anybody? Yeah, hypothyroidism, that's correct. So you want to order a free T4 and TSH. Actually, the T3 has no role in hypothyroidism. We usually order a T3 when we are thinking of hyperthyroidism. So in hypothyroidism, we generally ask for a free T4 levels and TSH. And when we want to confirm that like free T4 can be ordered along with a total T4 and a TSH. Okay, no role for T3 here. So what's the diagnosis? So what is this condition called as? Hypothyroidism leading on to precocious puberty. There is a terminology for this condition. Does anybody know what is this condition? So this is called as Van Wyck-Grumbach syndrome. Okay, so I'll just explain the basic funda of this. So we know this hypothalamo-pituitary thyroid axis. So the TRH, that is a thyroid releasing hormone from the hypothalamus, will act on the pituitary and release the thyroid stimulating hormone TSH, which will act on our thyroid gland and release the thyroid hormones T3 and T4. So when normal amount of free T3 and T4 are there, it will cause a negative feedback mechanism and inhibit the TRH. Now we are telling that this child has hypothyroidism. So when the T4 and T3 levels are low, there will not be any negative feedback. So the negative feedback is gone. So what will happen? The TRH will be increased in the body. So next what will happen? The TSH will increase in the body because the TRH is going to go and stimulate the TSH. So what this TRH will do is TRH will, apart from increasing the TSH, will also increase the secretion of prolactin, because TRH controls, like, increases both TSH and prolactin. So in this condition, you will also see a hyperprolactinemia. And this TSH, if you see, can also act on the gonadotropin receptors on the ovary. Okay, so it will stimulate the FSH receptors on the ovary and lead on to production of estradiol. So this only leads to breast development. So I told you this estradiol only is responsible for breast enlargement, uterine growth, and the endometrial thickness, which leads to menstrual bleeding. So all this can happen with only hypothyroidism, without your gonadotropins becoming involved at all, because this TSH is going and acting on the FSH receptor on the ovary. Okay, so why does the TSH go and act on the FSH receptor? How is it compatible? Because all the gonadotropins, that is FSH and LH and the TSH, have a common alpha subunit. Okay, and only the beta subunit is unique to each hormone. So because they have a similar alpha subunit, the TSH is able to go and act on the FSH receptor on the ovary and hence leads on to this precocious puberty features. Okay. Okay, so we'll just see the remaining questions. So this is the basic funda of Van Wyck-Grumbach syndrome. So the remaining questions are, so what's the diagnosis? I told you it is Van Wyck-Grumbach syndrome. What's the common etiology? So hypothyroidism in this age, what is the diagnosis? Like most probably, what is the etiology for this hypothyroidism? Like in congenital hypothyroidism, you have aplasia, dysplasia, ectopic, like that. In this age group, what do you think is the diagnosis probably? Anybody? Okay, so it is autoimmune hypothyroidism. So most common cases in the pediatric age group are autoimmune. So we have to order something called anti-TPO, anti-thyroid peroxidase antibodies and anti-thyroglobulin antibodies, which will be very much elevated. Okay, so you have to do these tests to confirm the etiology. So is it gonadotropin dependent or gonadotropin independent? So I showed you on the picture in the next slide. So is it GDPP or GIPP? Come on, people, I just explained. Is the gonadotropins involved or not? Nobody's answering. So was the LHFSH involved in that picture or not? So the TSH was only going and acting on the ovarian receptor, no? So the LH and FSH are not involved. So it is gonadotropin independent. Okay, so this is a cause of peripheral precocious puberty. That is gonadotropin independent precocious puberty. Okay, so what's the treatment? So would you use some drugs to suppress the puberty here? What would you like to treat the child with? To stop the menses, you want to use any other drugs? Why is nobody answering simple hypothyroidism? No, you should not use any estrogen inhibitors here. Yeah, it is only thyroxine supplements. Okay, when you correct the hypothyroidism, the precocious puberty will settle. Okay, so no need for any other drugs. Only thyroxine supplementation is enough. And what surgical condition can be associated? So sometimes these children will end up with acute abdomen, and retrospectively they will see that the child has hypothyroidism, because when the child has so much pain because of this condition, there will not be any tachycardia, there will be bradycardia. So at that moment they will think of hypothyroidism. So what surgical condition are we talking about? So it is something in the abdomen. So you can tell now what will happen in the abdomen. Acute abdomen. Anybody? So I told you where the TSH is going and acting, no? So what acute abdomen will happen? It is all there at the next slide I showed you. So the TSH is going and acting. Yeah, it is the ovarian cyst. So big ovarian cyst can be there, and it can cause ovarian torsion also. That is the reason for the acute abdomen. So what other hormone can be elevated? So that also I explained to you. So what other hormone? No, I'm asking what other hormones apart from thyroid and gonadotropins, which will be elevated. Actually, FSH will be suppressed. FSH will not be elevated. Here, it is gonadotropin independent. So only your TSH will be high here, T4 will be low. What other hormone will be elevated, I'm asking you. I showed you, TRH will increase something else also. Apart from your TSH, what will TRH increase? All of you are sleeping, huh? I just showed the picture. TRH will increase this hormone also apart from the TSH. Okay, so it's prolactin. Somebody has finally answered. So it is prolactin. Okay, so going on to the next question. So hypothyroidism is something very important for all the postgraduates. Okay, going on to the next question. So this is a 5-year-old girl with history of repetitive severe abdominal pain, just like the previous case, and has presented with acute abdomen. Ultrasound shows a right ovarian cyst, volume of 13 ml with impending torsion. On examination, you have something interesting. Cafe au lait spots are there. So you can see in the picture here, and genu valgum is there. So it is not hypothyroidism like the previous case. So you have a cafe au lait spot, you have cafe au lait spots and genu valgum. So you can see these cafe au lait spots on the chest, which are near to the midline. So from the midline, they are going to the right side. Okay, so that is one clue. And genovalgum is there, and there is the child also has on examination B2, A1, P1, and M1. So mummy didn't reveal any history because child is in acute abdominal pain, but on examination we found that child has very minimal TLAR and also had a menstrual cycle just before this presentation. Okay, so we'll go on to the question. So what's the diagnosis? So the main clues are on your examination: cafe au lait spots, genovalgum, ovarian cyst. Yeah, somebody's answered correctly. It is McCune-Albright syndrome. So what's the triad of McCune-Albright? So these are all exam OSCEs for you. Very important ones. Yeah, precocious puberty is one. In the skeleton, what can happen? I've put the X-ray here. What is this on the X-ray? So the triad is cafe au lait spots on the skin, precocious puberty which the child had, and fibrous dysplasia. So all three I have put it in the case. So fibrous dysplasias, cafe au lait spots, and precocious puberty. This is the triad of McCune-Albright. What other endocrinopathies can happen in McCune-Albright syndrome? Actually, hyperfunctioning of several hormone glands can be there. So it can involve the growth hormone axis, and it can cause acromegaly, it can cause hyperthyroidism, it can cause Cushing syndrome mainly in the infancy period, it can cause precocious puberty, and these fibrous dysplasias will produce something called FGF23, which will cause hypophosphatemic rickets. Okay, so these are the endocrinopathies which we see in McCune-Albright syndrome. So what is the genetic mutation here? So genetic mutation is, see, there is something called G protein coupled receptor. All of you know that, no? So there can be activating mutations of this GS alpha. So that leads to hyperfunctioning of several things. Okay, that's why we had all these endocrinopathies which are hyperfunctioning. So it is GNAS gene, GNAS gene. So in that there can be activating mutation of the GNAS gene. Okay, so how do you describe the cafe au lait spot here? So I showed you a cafe au lait spot. So the main differential for a cafe au lait spot of McCune-Albright is neurofibromatosis. So how do you differentiate a neurofibromatosis cafe au lait from a McCune-Albright cafe au lait? Okay, so I showed you very clearly that it was touching the midline, no, in this child. So McCune-Albright will mostly be in the midline, start from the midline and go to the side. So that is one clue, and it will have very jagged borders. Okay, that is called as coast of Maine appearance. Whereas in neurofibromas, it will be not in the midline, it will be in the sides, and it will have a smooth appearance. That is called as coast of California appearance. Okay, so what is the treatment of precocious puberty? Here we will use something called as letrozole, which is the aromatase inhibitor. Okay. And question 5, so what is this in the picture? Let's do this quickly. So this is a Prader's orchidometer. Okay, so what is it used for? Yeah, testicular volume estimation. So what does the number indicate on it? So you can see numbers 1, 2, 3, 4, 5, 6. What are all these numbers? Yeah, it is in ml. Okay, so the testicular volume in ml. Okay, so 1 means 1 ml is the testicular volume. And how do you measure it? So I put a picture here. So you have to keep the beads just beside the testis, and you have to hold the testis pole to pole so that the extra fat tissue and all is not there, which will cause falsely increased size. So nicely squeeze the skin and the underlying fat and hold it end pole to pole and compare it with the size of the beads and see what is the size of the testis. Okay, and what is the first sign of puberty in boys? Like in girls, we say TLAR. No, for boys, what is the first sign? Yeah, it is gonadarch. Okay, so increase in testis volume is called gonadarch. And what testicular volume indicates mark of puberty? I mean, start of puberty. Yeah, 4 ml. That's right. Okay, so going on to question 6. So this is a 14.5-year-old boy brought with short penis. Okay, this is a common complaint for, like, parents are very much worried if the child has short penis. and height is 143 centimeters. So you can see that the child at 14.5 years is just below the third centile, and weight is 35 kg. That is also on the lower centile lines. Okay, so child is looking like an undernourished child. Height and weight are both on the lower centiles, and that lower centiles has been from the beginning. Okay, so usually from 2 years itself they will be like this only, always just running parallel to the lowest centile lines. So that malnutrition component is there. In SMR, if you see, child has a testicular volume of 5 ml. Okay, and P2, pubic hair stage 2 is there, and is SPL, stretch penile length of 5 centimeter. So this child has just entered puberty. Okay, so the testicular volume is 5 ml and just pubic hair is started. Okay, and so penile length is shorter. Usually it is from the testes that the testosterone will be released and it will act on the penis, and penis should increase in length. So it will take some time from the onset of puberty to the penis to increase in length. Okay, because a child is just in stage 2 of genital stage 2, that is testicular volume is just 5 ml, the penis is yet to lengthen in size. Okay, so this child is in early puberty with just few pubic hair and small penile length for age. Okay, and dad is giving a characteristic history of shaving around 17 years. So that is late bloomer. We tell late bloomer. So dad will tell that I was also remaining short for a long time. And then when my peers started to have mustache and beard, I did not have. Later on, I had a growth spurt. When others had finished growing, this dad will start to have a growth spurt, and then he will have a delayed onset of mustache and beard and delayed shaving history. So that is very characteristic, late bloomer. Okay, so the dad gave this history. So what's the diagnosis? Yeah, it is CDGP. So Anurag sir has already told you this. I put it as early puberty, but you may see this child around 13.5 years with just P1 and 3 ml testes. Okay, so this was a 14.5-year-old child. Usually average age of onset of puberty in boys is 12 years. So 12 years they will enter into puberty, but this child early puberty is seen at 14.5 years, which is because of the CDGP. Okay, so what will you expect in the bone age? So this also Anurag sir has covered. You will see a bone age delay. Approximately 1 to 2 years bone age delay will be there. And what is the treatment? So this child has already entered puberty. You should know that this is not the same case that Anurag sir had put, who's pre-pubertal. This child has come for short penis, but just has entered puberty. So what would you want to do in this case? Yeah, wait and watch. Because child has already entered puberty, I would like to wait and watch, see the pubertal progression and then decide. Suppose a child had presented a year earlier, like at 13.5 or 14 years with pre-pubertal testes of 3 ml and P1, I would think it a CDGP and give 3 shots of testosterone and wait for some time and re-measure the testosterone and see. Okay, that sir has already explained. So we will go to the next case. So this is question number 7. A 14-year-old boy brought with complaints of prominence of breast tissue. Okay, and SMR is A2, P3, and testis is 6 ml bilateral. So this boy is also in early puberty. 6 ml is only the testicular volume, and he has gynecomastia. Okay, so the close differential for gynecomastia is lipomastia. So how will you differentiate a gynecomastia from lipomastia? So you always make the child lie supine, put his hands behind the head and rest, relax, and then with your thumb and forefinger just palpate underneath the areolar complex. If you can feel a firm rubbery concentric disc-like thing under the areolar complex, then it is the glandular tissue of the breast. If nothing like that is there, then this is lipomastia. Okay, so a rubbery firm disc-like structure should be felt just below the areolar complex. Okay, then it is glandular tissue, that is gynecomastia. If nothing of that sort is there and child is obese, it might just be a lipomastia. Okay, so in that case, you will just advise weight loss. So this was a characteristic gynecomastia. So what test would you like to do here? So basically, you should understand that gynecomastia is because of increase in, there is an imbalance between the testosterone and the estradiol levels in the blood. Okay, that is the reason for gynecomastia. So little estrogen is more compared to the testosterone. In early puberty, usually there will be this imbalance, but as the puberty progresses, the testosterone will increase in the body and inhibit the breast tissue. Okay, so because the child is in early puberty, because of this imbalance, gynecomastia can be seen in many children. Okay, so I would like to do some basic blood tests and see if it is normal or not. So the basic blood test will be free T4 TSH, liver test, because any liver condition also will inhibit the metabolism of the androgens and increase the conversion to estradiol. So in LFT will be done, creatinine will be done. Any chronic kidney disease, chronic liver disease, hyperthyroidism, and if any hypogonadism is there, or estrogen secreting tumors or aromatase excess, something like that. So when the testosterone is low or the estrogen is high, this can lead to gynecomastia. So you have to think of conditions where testosterone is low and estrogen is high. So do the tests accordingly. And if the tests come normal, then what will you think of? So the testosterone is pubertal range, LH is pubertal range, and other tests are normal. You will think of pubertal gynecomastia. And I told you what is the reason for breast tissue development. So the treatment here, basically pubertal gynecomastia, we will just reassure them and we will tell it is a self-limiting condition. Within 1 to 2 years, it will generally settle. So just wait and watch. And the basic thing I've just put here, which we will give in the handout, because of lack of time, I'm just skipping this. How is the estradiol being produced in boys? And so these are the causes of high estrogen and low testosterone in the boys. So you can just go through all this. So we'll go on to the final question. In 2 minutes, I'll finish it, sir.
Thank you. Thank you.
Yeah. Okay. So this is a 18-month-old toddler whose length is above the 97 centile, 92 centimeter. So we expect 1.5-year-old child, 92 centimeter. So he's tall for age, and rapid increase in penile length and frequent erections from 10 months of age. Okay. And SMR is A1, P2, and penile length is increased 7.5 centimeter. But the testes are prepubertal, 3 cc and 2 cc only. Okay, so there is a prepubertal testis with a long penis and pubic hair, and bone age is advanced. So height is advanced, bone age is advanced. So there is some androgen source here, but not from the testis, because testis is not enlarged, so it is not coming from the testis. So what is the diagnosis? So diagnosis is gonadotropin independent precocious puberty here. Okay, so that has only led to the increase in penile length and pubic hair. So what are the causes in boys? As a postgraduate, the most important thing you should remember is CAH. So a simple virilizing CAH can usually present between 3 to 4 years of age. But this child at 1.5 years was quite early, and this child actually had an adenocortical tumor. So usually testicular tumors, adrenal tumors, CAH and hypothyroidism McCune-Albright can cause this. So first line investigations, you should just remember for CAH. So CAH, basically we do 17-hydroxyprogesterone, DHEAS, testosterone, cortisol, sodium, potassium, and glucose. So just remember this. Other causes adrenal and testes. So you have to do ultrasound abdomen, ultrasound of the testes. So this I've just explained. No? Prepubertal testes with increased penile length, no gonad is there. So it is GIPP. So these are the answers. So if there is any query, I'll answer it later on. So we'll proceed to the next session. Thank you, sir.
Thank you very much, Dr. Soundaram. She has prepared for the last 3 to 4 days, day and night. Very excellent question answer session and very ideal. Thank you very much, Dr. Soundaram. Now I request next presenter, Dr. Leena, to present the case of precocious puberty. For this, examiner will be Dr. Anna Simon, Professor of Pediatrics and Pediatric Endocrinology from CMC Vellore. Madam is a very good examiner, teacher, author for textbooks, and internationally known faculty. Over to you, madam.
Thank you.
Soundaram, you stop the screen, no?
Sorry,
Stop
sorry.
sharing.
Yeah,
Stop
yeah,
sharing.
sorry.
Yeah. Yeah. Leena, please.
Yes, sir.
Dr. Leena is a student from Apollo Chennai, student of Dr. Soundaram. Yeah.
So is my screen visible, sir?
Yes, yes.
And am I audible?
Yes, audible.
Okay. Good evening, all. I'm Dr. Leena from Apollo Children's Hospital. And my mentor is Dr. Soundaram, and Dr. Yoga will be helping me out with the questions posted later. So I'm going to present a case on central precocious puberty. So we had an 8-year, 8-month-old girl who was brought to us in the month of February 2021. And she came with complaints of rapid increase in height for 1 year. And for 6 months, she had increase in breast development. And for 3 to 4 months, she had axillary and pubic hair development. She had also attained menarche before 10 days. So the both breasts were equal in size and slowly growing in the last 6 months. She also had complaints of pain when touching the breast, initially in the 2 months, which then subsided on its own. And the hair development, that is the axillary and pubic hair, for the last 3 to 4 months, it was found to be thick and bushy. She also had white discharge for a month before menses, and menarche was attained 10 days ago, and it was characterized by spotting only for 2 days, and she used only 1 pad per day, and there was no history of dysmenorrhea. So the child was always one among the tallest in the class. However, now it was noticed that she was much taller than rest of the class, and the family members also noticed that the dresses which were brought last year were not fitting the child anymore. And all these features were not seen, like headache, vomiting, visual disturbances, and no use of tea tree oil, lavender oil use, and no use of cosmetics, no history of head trauma. So the treatment history, the child was diagnosed to have early puberty and started on injections in March 2021. Initially, it was given once in 4 weeks for the first 2 doses and then once in 12 weeks. She also received vitamin D supplements along with that. And after the start of treatment, she had 1 menstrual cycle 2 weeks after the first dose, and it lasted for 5 to 6 days with normal flow, and it was also pain-free, and like the patient did not have any dysmenorrhea, and thereafter no further menses.
Can I just interrupt at this moment? If you go back to your history, the progression of the puberty has been so fast. I'm not sure whether I am commenting because I don't know, because you have seen the patient, everything is possible. But you said that there was height acceleration for the first 1 year, and then telarchy started 6 months back, and menarche within 6 months of telarchy. That is not the usual physiological kind of puberty progress. Do you have any explanation for that? Normally, girls can achieve telarchy after 8 years, and after 1.5 to 2 years of telarchy, you develop menarche. And height acceleration occurs in stage 2, Tanner. Okay, so I mean, your patient has some features which are very atypical because there is a height acceleration for 1 year, breast development over the last 6 months, and menarche within 6 months of breast development.
Yes, ma'am. It was
the
rapid.
tempo of the pubertal progress is not very typical. Do you have any explanation for that?
No, ma'am. She presented like this only, ma'am. It was a rapid progression, ma'am. The normal tempo was not found in this child.
Dr. Saundram, please help her. So actually, history was little modified, madam, about the height and all. Dr. Saundram, please help.
Actually, I felt that maybe the parents did not appreciate the breast development early on. They noted it only after it was quite significant.
Sometimes we will have to give leading questions to the parents to find out the exact sequence, because the tempo of progress of puberty also has some relevance with regard to the prognosis and the cause of this precocious puberty. Then the other comment I wanted to make was, when you say treatment history, it is a treatment prior to what has happened. You have given the management of this patient as treatment history. Am I right?
Yes,
so
yes,
the
ma'am.
treatment history is the treatment happening prior to this, which has an implication on the diagnosis. This is the child's management which happened after you made the diagnosis. This is not treatment history.
Okay,
this is one comment that I have to tell you. This is actually the management which followed your diagnosis.
Yes, ma'am.
So, yeah, so that I think has to be noted very well. When we say treatment history, it's a treatment which happened during the course of the illness or preceding this illness, which has contributed to the development or may have not contributed. This is the management of this case.
Yes, ma'am.
Right.
I'll proceed, ma'am.
Yeah,
Yeah, just a second, Lena. Just go back and you tell us why you asked all those negative history, please.
Headache, vomiting, visual disturbances to rule out any intracranial space occupying lesions, sir. And the tea tree oil, lavender oil, they seem to possess some estradiol-like actions. So that negative history was asked because of that. And cosmetic use, some cosmetics they do contain some chemicals which tend to increase the rate at which the puberty is attained, and also head trauma is known to cause early puberty.
So I would like to add here that the use of soya products, soya milk, soya chunks, oil do given phytoestrogens, which can actually lead to breast development. And that's one question that you can ask about
Yes.
soya products. There are a lot of phytoestrogens in the soya products.
What specific history you want to ask if child is male?
The child is male, sir.
Yeah,
The intracranial space occupying lesions are more commonly
that you told something extra, not in female but males.
May I help also?
And
Sorry.
any, yeah,
Yes, sir.
something to do with the behavior, laughing in a
gelastic
prep.
seizures, sir.
Yes, very good. Yeah, go ahead.
So, past history, there was nothing significant found and no prior hospitalization history. And she was born by normal vaginal delivery. Birth weight was 2.7 kg, and she was an adopted child. The biological family details are not available. So, she was appropriate for age, developmental wise, and also her scholastic performance was found to be good. And as far as the diet history is concerned, she is on vegetarian diet, and the calorie intake was 1620 kilocalories, which she had, but the required was 1800, and there is a deficit of 180 kilocalories. And protein intake was 22 grams, and the required was 35, and the deficit of 13 grams was noted. And according to modified Kupuswamy scale, she belongs to upper class family. So to summarize, we have an 8-year, 8-month-old girl with early onset breast development, pubic and axillary hair growth, rapid progression, and had menarche within 6 months. Growth spurt was present, no symptoms of raised ICT, and not SGA at birth.
One more
So,
comment I have is that you on a calorie and protein deficit diet, she had very good height acceleration. I think the dietary history should be taken more carefully. According to
yes,
what you said, it's a calorie deficit, protein deficit, and as you all know, puberty usually happens when there's an energy excess. Fed state, a certain BMI, is known to be necessary for stimulating the puberty onset. So that history probably will have to be redone. Whether there was a real calorie deficit and protein deficit in the diet doesn't go well with the presentation.
yes, ma'am. I'll proceed now.
Yes, proceed, please.
So the provisional diagnosis of precocious puberty is made. So for physical examination, child was alert, active, and vitals were all stable, and no pallor, icterus, cyanosis, clubbing, or lymphadenopathy or pedal edema was found. There was no goiter, no cafe au lait spots, and no abnormality of the limbs. So her height was 145.2 centimeter, which was found to be in the 97th centile.
Just a second, Lena.
Yes, ma'am.
In general physical examination, if you're thinking of intracranial space occupying lesion, you have to examine something you're missing here. What is it?
The head circumference, sir.
What is
Um,
something in the eyes? Something in the eyes.
Lady
yeah,
Yes.
Papillary.
Fundus examination you should do. Yeah, go ahead.
So BMI was 17.03. Her weight age was 11 years 3 months, height age 11 years 3 months, and chronological age of 8 years 8 months. So the height age and weight age were found to be more than the chronological age. So systemic examination was found to be normal. There is no abnormalities detected. So to summarize, 8-year 8-month-old girl with early onset breast development, pubic and axillary hair growth, rapid progression to menarche, and presence of growth spurt, no symptoms of raised ICT. And on examination, SMR was A2, P3, B4, M1. Vaginal mucosa was pink and pale, and no mass was palpable per abdomen. And
So
provisional.
one more comment here, when you are looking at the eye, of course, we have to look for signs of papilledema, and you often get symptoms of raised ICP. But what is often missed with most of the central tumors are of defect in the field of vision. So confrontation technique and field of vision is also some important sign when we are looking for when we are examining these cases.
Yes, ma'am. I'll proceed, ma'am.
Yes.
So provisional diagnosis of precocious puberty.
Let me ask you one question at that moment.
Yes.
Given that you have got this history,
Mm.
do you think this is central precocious puberty or is it a peripheral precocious puberty? Basically, whenever we assess a child with precocious puberty, the first question is it precocious? Yes. The second question is it central precocious puberty or is it peripheral precocious puberty?
I think it is central, ma'am.
Yes. Why?
Because there are no signs of any abdominal mass or.
No. More important than that, it has all the components of puberty. Am I right?
Yeah.
So that's very important. Most of the time.
Also isosexual.
Isosexual, and most of the components of puberty will be present. So this more looks like a central precocious puberty.
Yes, ma'am.
Yes, go on.
So the investigations.
Just 1 second, Lena, can you tell the normal sequence of puberty in females? What is the normal sequence, including
First,
growth spurt? Yeah.
we have thelarx.
Very good.
And then we have the pubic axillary hair growth.
What is that called? Pubarc. Yeah.
Pubarc. Yeah. Growth spurts.
Yeah.
Menstruations.
Yeah. Go ahead.
Yes. So hormonal profile was tested. LH was found to be 5.2, FSH 5.3, estradiol 40.
What is your interpretation of that? Basal, is it basal? Basal values of LH, FSH, and estradiol. What is your interpretation?
LH, FSH is found to be raised, ma'am.
Yeah, so
pubertal
what is your interpretation of that? Yes.
Pubertal.
Does it confirm something which you clinically on examination decided? Does it confirm?
It's a gonadotropin dependent cosmet.
Good. So it's a true precocious puberty. Gonadotropin dependent precocious puberty.
Yes, ma'am. So free T4 was 0.8, TSH 1.16, and prolactin was 5.6. So bone age was 12.4 according to TW3 and 13.4 according to TW2. So ultrasound abdomen was done. Uterine dimensions were.
Just go back. You tell how much is the bone age advancement. You need to tell here. What is the normal bone age advancement, and in your case, how much?
What is this, sir? I didn't get the question.
What is the chronological age of this child?
Chronological age is 8 years, 8 months, sir.
Yeah, you tell how much is advanced, how many years. What is the normal advancement? Do you know what is the normal advancement during puberty or during even normal for the age? Standard deviation.
2 standard deviations.
Yeah.
10% of the age. Suppose child is 10 years, so plus or minus 1 year. So up to 1 year advancement is normal. So here, how many years?
4 years, 4 to 5 years.
This is abnormal. Yes, go ahead.
So the uterine dimensions were found to be 5.9 into 3.8 into 3.1 centimeter, and the thickness of endometrium was 8 millimeters, and both ovaries measured 11 ml, and it had multicystic appearance, but there was no evidence of any mass lesion. So this is the MRI brain which was done, and it was found to be normal. So the diagnosis is made to be idiopathic central precocious puberty. So the management. So injection leuprolide.
Just a second, one question here. When you will think of organic lesion, in which conditions you will think puberty is due to organic lesion?
When there is accelerated precocious puberty, we should definitely think about the organic causes, sir.
What is, which sex, male or female?
In males.
Of females.
Very good. Below what age?
6
Less
years.
than 6 years.
Very good. And signs of intracranial tension. Very
Yes.
Okay.
Yeah, go ahead.
So management. Injection leuprolide acetate was given. 3.75 mg deep IM was given for 2 doses, 4 weeks apart. And vitamin D, 60,000 IU, 1 sachet every alternate month was given. So during the follow-up, in April 2021, estradiol value was found to be 11 and LH was found to be 4.9. Hence, leuprolide was switched to 7.5 mg IM, followed by 22.5 mg IM once in 12 weeks.
Why was a stimulated LH done on treatment with GNR channel?
Actually, the child was already undergoing treatment, and that treatment dose was taken as the stimulus, and LH was measured after that.
Ma'am, actually, we did not give any decapeptyl here, ma'am. The leuprolide dose, which was due, the same leuprolide dose we gave, and 2 hours after the leuprolide treatment dose, we will check the LH, ma'am.
What was that meant for? You had already made a diagnosis of central precocious.
Yes, ma'am, but was that 3.75 mg adequate to control the pubertal features? We wanted to check because mom was telling that the breast development was little increasing. So to check that, I had done this stimulated LH value with the treatment dose itself. So it came high, so we switched from 3.75 to 7.5 mg.
Treatment failure. You're considering a treatment failure and you wanted to redo the GNR channel of stimulation, right?
Yes, sir. Yes, ma'am.
Any other questions? I think we had extensive.
Yes, madam. I think madam has some net issues. So usually when we give GnRH analog, there will be initially stimulation followed by there will be suppression. So after giving injection of GnRH, we are checking after 2 hours for suppression. But suppression will take some time. Means at least after 2 injections only there will be suppression.
Actually,
So they should, yeah.
This was done after the second dose only. So when she was due for the third dose, we had done this.
Okay.
First dose she had menses, we did not do anything. We knew that there will be a flare. After the second dose also, there was some progression in the breast development. That was a concern. So when we are giving the third dose, the stimulated value was done actually when we gave that.
Yeah, thank you very much. A small question to Leena. Can you tell about the what is GnRH stimulation test and when you want to do?
GnRH stimulation test, we give GnRH and then we measure the hormone values, sir.
Yes,
so
very good.
we do it to diagnose and also to see whether whether there is any treatment failure or not.
What are the indications when you want to do?
So can I take this question, sir?
Yes, please. Yes.
When we are suspecting central precocious puberty, but if the LH levels are normal, then we go in for the GnRH stimulation test.
Apart from that, any other condition mimicking like precocious puberty? You have discussed so many cases, no? Premature thelarchy, whether it's a progressing or not, it's very important. Raghupati sir, sir, you have any questions? Madam is not there.
I just wanted to say one technique which the examinees can follow, not only in endocrinology, in every other subject also. It is, in this case, for example, if you had said two central isosexual precocious puberty, it impresses the examiner. I can tell you that. At least I will be impressed. And then what will I do? Why do you say two? Why do you say central? Why do you say isosexual? And you go ready with the answers, and you can score more marks, and you can be very impressive also. After all, we are not saying anything out of the way. That is the diagnosis. And it's also one of the ways to learn all the components. It is a true precocious puberty. Then they will say, what are the causes? Pseudo puberty. So you can be prepared with the answers, and you can lead the examiner to ask you the questions which you want. Otherwise, they will ask you some other question. Do you understand what I'm saying?
Yes, sir.
Okay, that's a very clever way of leading the examiner. Okay.
Yes, sir.
I just wanted to mention that.
Thank you, sir.
Yeah, madam is coming back. She called just 1 or 2 minutes. Sir, you have any questions, sir?
No, I'm quite happy with what she has said.
Yeah.
There is one question in the chat box about 22.5 being given 6 monthly. It is active only for 3 months. So it is given for 12 weeks and 6 months, no. Okay, go ahead.
Yeah, Dr. Divya, you have any questions? Please ask. Madam will be joining shortly.
No.
Sorry about that.
Yeah. Thank you, madam. Please, over to you.
Okay. Fix my PowerPoint. Just a minute, let me share my slides.
Lena, I think you have stopped sharing.
I stopped, sir.
Yeah. Yes, madam. We are able to see, madam.
Okay. So I think lots have been said, and all of you are fully knowledgeable by now. We'll quickly go through precocious puberty. But the main challenges which when we deal with precocious puberty is like identifying children with pathological forms or whether they are different normal variants of pubertal development. And that is the most important thing, like how we went through the first case, the previous case, and to decide whether it is central precocious puberty or peripheral precocious puberty or whether they are a normal variant. That is the first step in the challenge in managing precocious puberty. We definitely have to know whether it is central gonadotropin dependent or gonadotropin independent, because that's very crucial for planning appropriate investigations and treatment. So it's important to know something about normal puberty, which I think is going to bore everyone now because we are at the end of the session and the sequence. So all of you know what puberty is. I'm not going to go through it. And puberty is actually starts from activation and maturation of the HPG axis. Simultaneously, there is maturation of the adrenal cortex also. So it's a process where there is a physical maturation and an adolescent reaches sexual maturity and he becomes capable of reproduction. Usually it starts between 8 and 13 in girls and 9 and 14 in boys. And you can see there are a lot of emotional and hormonal changes along with the physical changes like increase in height and weight, thelarchy, which is breast development, pubarchy, and genital changes in boys with voice changes and menarche. We don't have to go through that in detail. And all of you are aware that this starts from the pulsatile release of GnRH, from the hypothalamus, and it happens with an energy sufficiency or excess state, and with the role of kisspeptin. And GnRH thereby acts on the pituitary gland, producing the gonadotropins, FSH and LH, and they all have a feedback mechanism also. And LH and FSH act on the gonads, producing the sex hormones. So we can skip that. And these sex hormones make changes in the physical and emotional changes which happen in the boy or the girl, leading on to pubertal development. There are variations of normal pubertal development. The most common is premature thelarchy and premature adrenarchy. These conditions do not require any treatment, like I said before, only reassurance and a follow-up of every 3 to 6 months. So premature thelarchy is, I think this has all been said, but I just want to reiterate that it's self-limited, not associated with the height accelerations, can be unilateral, bilateral, and very young girls, it can regress also. And if you're very worried about whether it's just premature thelarchy or not, a GnRH stimulation test can help to differentiate whether it is CPP or just premature thelarchy. Premature thelarchy does not require treatment, but it mandates very close follow-up to know whether they don't rapidly progress to CPP. Premature adrenarchy happens more frequently in girls than in boys. We should differentiate the benign form from pathological forms. That is very important because premature adrenarchy as a peripheral precocious puberty, most often they are pathological forms. So the benign premature adrenarchy starts, the bone age advancement won't be more than 2 years from the chronological age, or it may even be equivalent to the height age. And when you look at the serum levels of DHCs and testosterone, they may be mildly elevated, but it will be appropriate for the skeletal age. And the most important thing is there is no sign of gonadal maturation, either in boys or girls. That is saying that the testicular size will remain the same, though there are other changes of pubertal development. And if you see clitoral hypertrophy or hirsutism in girls, then it is definitely a pathological adrenarchy. So this is how the height progression happens. As you all know, this chart just shows that the height acceleration occurs in the early phase of pubertal development in girls, whereas in boys, it happens in the Tanner 4 to 5 stage. And that information is relevant to us when we take history. So we know at what stage of pubertal development the child is. So when we call precocious puberty, if puberty happens before 8 years in girls or before 9 years in boys, then it is precocious puberty. And it's very important to differentiate whether it is isosexual precocious puberty or heterosexual precocious puberty. Heterosexual precocious puberty is always pathological. Isosexual precocious puberty can be differentiated again into gonadotropin independent or gonadotropin independent, as we have gone through before. So the questions we ask is it precocious? Is the child too young to have reached this milestone? What is the cause of this? There's other signs attributable to androgen or estrogen. And what is the source of this sex hormones? Where is it coming from? Is it physiological or pathological? And how far advanced the puberty is and how rapidly it is progressing. So these two aspects are very important when we decide on the management of these children. And of course, we have to ask ourselves, is treatment really indicated? So when we look at gonadotropin dependent precocious puberty, it's otherwise called true precocious puberty or central precocious puberty. That's premature activation of the hypothalamic pituitary gonadal axis. And most of 90% of precocious puberty is actually gonadotropin true precocious puberty, where you have gonadarchy and plus, and most of the time adrenarchy progressing along with the gonadarchy. And idiopathic causes are the most common, especially in females. You can see that the ratio is 10:1. And if it is closer to the normal age of development, like closer to 8, then it's most likely just the early normal physiological puberty, and we don't have to elaborately do MRI. MRI would be considered if the child is less than 6-year-old and has other problems denoting CNS abnormalities. And as said before, apart from CNS abnormalities, we should also look at the familial causes where puberty can be early, or it can be if a gonadotropin independent puberty, which was not managed well or treated, like example in CH, you may have cerebral CPP developing in a gonadotropin independent puberty. So that aspect also should be considered. Investigations, as we all seen now, we look at the growth velocity and the bone age. It's very important. Sometimes if you have multiple pituitary hormone deficiencies, growth hormone deficiency may mask the pubertal growth spurt. So height acceleration may not be seen when you have multiple pituitary hormone defect. Basal LH, FSH, estradiol or testosterone will help you to differentiate whether it is CPP or peripheral precocity. Rarely, you may have to do a GNRS stimulation test to make the distinction. MRI brain and pituitary should be done only when it is indicated. So here is a child with a hypothalamic hamartoma, as you can see, and this child had presented with precocious puberty at 2 years of age, with all the full components of precocious puberty. So CNS tumors are common in younger children, and if there are signs of CNS involvement, we have to carefully do an MRI scan and make the diagnosis. And the treatment considered will depend on the cause. And treatment should be considered with GnRH analogs if definitely the final height is compromised, and depending on the tempo of progression of puberty, if the progression of puberty is very fast, or the child is unable to cope emotionally and socially with the puberty. As you said, if it's a primary cause, the tumor has to be addressed, or GnRH agonist, as we said before, for 12-weekly depot injections to suppress the gonadotropin hypothalamic pituitary gonadal axis. Gonadotropin independent precocious puberty, it comes from exogenous sex steroids, or it can be from tumors from the adrenal gland, gonadal gland, most common, and rarely hypothyroidism, as was said just now. That's a rare cause of, or an unusual cause of gonadotropin independent precocious puberty, secondary to high levels of TRH and TSH levels and the similarity of the alpha subunits. So the causes of gonadotropin independent puberty, there can also be autonomous ovarian function, like we saw in the McCune-Albright syndrome or other ovarian tumors, or in the testis, testicular or germ cell tumors, or activating mutation of genes for the LH receptor, right, for male limited gonadotropin independent puberty, like testotoxicosis or McCune-Albright syndrome in the boy also. Here the investigations may be different depending on the cause of the peripheral precocious puberty. We may do different causes. We may decide to do a DHES, adrenal steroids like 17-OHP DHES, or an ultrasound of the adrenal or gonads. HCG and alpha fetoprotein as tumor markers also may have to be done if you are dealing with the peripheral precocious puberty. And the treatment of peripheral precocious puberty is highly individualized and managed accordingly based on the etiology, the predicted adult height, and other psychological concerns. So I just wanted to show you the same skin lesion, cafe au lait spots. Of course, somebody showed a McCune-Albright earlier, but here is a child who came with NF1 neurofibromatosis, and he had central precocious puberty to an aptic glioma, which was impinging very near the hypothalamic area. So that's also possible. The same way, again, another McCune-Albright spot, the ragged mane of coast of mane appearance, and fibrous dysplasia, McCune-Albright syndrome. So what I would like to reiterate here, points to remember us, first thing is we have to distinguish precocious puberty from normal variants of pubertal development. Secondly, we have to distinguish whether it's central precocious puberty or peripheral precocious puberty, because the investigations and management will change according to what it is, and planning of those investigations can be done ideally only after distinguishing whether it is CPP or whether it is a peripheral precocious puberty. Unnecessary investigations should be avoided if features of precocious puberty are inconsistent or not clearly evident, and we can follow up the patient after a few months for reassessment. Reassessing the patient at every intervals of 4 to 6 months may help you to come to a conclusion in which direction we have to investigate. Suppression of true precocious puberty with GnRH analogs should be considered if there is significant compromise to adult stature and there are other behavioral issues secondary to early pubertal development. Otherwise, we may not have to treat if the height is not compromised and the family is able to cope with it. With this, I will end my talk.
Thank you very much, madam. Uh, in spite of madam busy schedule, and we hope madam's mother is well and she will recover good. Uh, we thank all the participants, the examiners, examinees, and professors, and Dr. Shaila Bhattacharya, and all the students who had made this PEP an excellent session, especially Dr. Soundaram presenting the OSCEs, and Anurag sir, madam giving a very excellent lectures. Over to Raghupati sir.
Uh, Congratulations, Amarnath, for another successful PEP program, and I hope everybody liked it. And as you said, the very first case was a good eye opener for most of the postgraduates attending. And Dr. Anurag simplified the approach to this. And Sundaram had emphasized all the practical points which they should know during an OSCE exam. That was quite good. And Lina's presentation also was very nice, appropriate case. And Dr. Anna gave you so many points to remember and to distinguish physiology from pathology. And I'm very pleased that we had another successful session today. Thanks to Amarnath, thanks to all the participants, the panelists, and the faculty. Thank you very much.
Yeah, I especially thank Raghupati sir. He's always student friendly. When I used to be a student, and even for all postgraduate, used to take the cases from the OPD and go to the general pediatrics department and say. So what we need present day is blessings of our teacher and skills rather than the knowledge. So we need to get the skills from the teacher. More than that, love and affection of a teacher is very important nowadays, and even love and affection towards the patient. Those are the real blessings of the knowledge and the doctor-patient relationship. Madam, one or two words from the Anna Simon, madam.
Yeah, thank you, Dr. Raghupathi, sir. And it's been a great example. Nice to see you and nice to participate in this session with you. Thank you very much. And Dr. Soundaram, you had an excellent collection of OSCEs. I think you covered the whole of puberty with your OSCEs. That was nice. Yeah.
Yes.
And Amarnath, thank you very much for your wonderful work.
Yes. We thank RX event people and the mainly Shaila madam for giving this platform. And we'll be coming in next October session with very interesting topic, achondroplasia and other interesting cases. Thank you very much. Once
Amarnath,
again,
do you want to ask for any feedback from the attendees?
yes, sir. Yes.
They could send some feedback, so that will help us to plan future sessions also. And they can say whether it was useful. I mean, they can be open about it, and that's the whole idea. And if you don't want to mention your name, okay, fine. But we would like active comments, whether you liked it, whether you wanted some other aspect to be emphasized, whether it was too much, too little, or to the point, things like that. So I would
Yeah.
like to get some feedback from the attendees.
Yes. Anyone? Just I need a 5 seconds, sir, to cover the questions. Just 5 seconds.
You can write to us by
Yeah.
email also.
Yeah, just last one slide, 5 seconds. These are the questions, theory questions are coming from the puberty topic. Already you know most of the things covered. Physiology of puberty, normal physiology. They are asking diagnostic approach to precocious puberty, premature thelarchy, investigation management of delayed puberty. Once they asked about the virilization. So please note this extra question. Define and classify precocious puberty. Outline diagnostic approach. 14 years old boy with infantile genitalia. So, these are the question. Thank you very much. Uh, we, uh, we want the feedback. I think Leena, you can tell, or even Yogavalli. Yes.
Yes, sir. Actually, I'd like to thank Dr. Amarnath and also Dr. Raghupati for giving this wonderful opportunity. And even if I had read my books 10 to 15 times, I wouldn't have got such an experience. It was really great to do this presentation with you guys as my examiners, sorry. And also I'd like to thank Dr. Soundaram for giving me this opportunity and selecting me from our institution. And also I like Dr. Naga Geeta's presentation. It was really great. Thank you. Thank you, sir.
Yeah. Thank you all. Yogavalli, you want to say something?
Uh, yes, sir, very sorry for the bad throat I have. Yeah, this was really a useful presentation, sir. Especially like the OSCEs were very useful, and both the presentations were really good. It was very useful, and regarding this endocrine, mostly like we go like I mean we are sometimes like clueless like how to proceed all, but this definitely showed us an excellent protocol for like how to proceed, and Dr. Soundram definitely she guides us in our clinical aspects in all our cases what we receive, and this was really useful, and we'll definitely apply this in our like cases like which we get in our future, sir. Thank you so much for the opportunity, sir, and everyone. Thank you.
You had the photographic evidence of how Soundaram is being helped by her son actively, so she could do it so well.
Yeah. Very energetic and dynamic, sir. She is.
Just joking. We enjoyed
Yeah.
the OSCE session, Soundaram.
Yeah. Thank you all. We pray for the long age and more blessings of Raghupati sir towards us. He is one of the first pediatric endocrinologists of India and one of the first professors. So we like you, sir. We need your blessings for all your student community in future. We need you and your blessings and love. More than that, love. Sir is always loving. So he cancelled all his appointments today.
It will be all the blessings will be raining as the monsoon today.
Thank you so much. Thank you so much. So, with this, we'll end the session. Wishing you all the best for your exams. You will. We pray that you all will become professors and teachers and other for textbooks. Please opt pediatric endocrinology after your MD pediatrics or DNB pediatrics. Very interesting and learning subject and more satisfaction giving branch than any other super specialty. Thank you.
Thank you, sir. Thank you so much, sir.
Yeah.
Good night.
Thank you, sir. Good night, sir.
Thank you.
Well done.
Thank you, sir.
Thank you.
Well done. Bye.